Okay.
Yep.
So what I'm gonna do, like I said, I'm gonna have Emily put us into breakout rooms, and what I'd like for us to do is be in the rooms for about 20 minutes. And in these rooms, I would like for you to create an intervention of some sort that addresses a chosen health issue. So your group can talk about what type of intervention or what type of health issue, and then what type of intervention you'd want to do to address that health issue. And the intervention in particular needs to address certain things. So I would suggest that you either have somebody volunteer or volunteer someone to write down the following things, because when we come back together, we'll have a chance to kind of report out and discuss what we talked about, and think about what those justifications are for these different designs. But first, I want the groups to select the most appropriate design to address that health issue. And that's just based on, like I said, the information that Dr. Wickman had given in his presentation. And then also, if you have time, I don't know that we will, but if you have time in your group to do more than one design, feel free to do that. But definitely if you want to spend time on one and do it really well, that's totally fine too. And then once you've figured out what design is most appropriate, identify 2 to 3 of the most important reasons why you think this is the appropriate research design for the chosen health issue, and then of course the intervention that you're choosing to implement. In addition to that, identify 2 of the most relevant strengths for the design you selected. If you selected more than one, then for each design, and then 2 of the most relevant weaknesses for each design that is selected. All right, we are all back. So we can all chat. So since I'm facilitating, I'm going to start with Paul's group and let us know what you all talked about.
Let's see, Aisha, do you want to talk about it?
So I can start a little bit about it. So we were talking about the peripheral artery disease patient in the population. And what we're trying to look into those patients is what is going to make them walk more to increase the physical activity, because they have onset of pain, which is called intermittent claudication. So we were thinking of what we're doing is that we're giving them an intervention, which is orthotic device, and in normal words called a brace. So an ankle brace. And then we're randomized control trial would be a good way. We'll have a control group, which we do, and then it's a 3-month intervention. And the weakness is per se, Dr. Estabrooks, would you want to elaborate what would be the weakness in this?
Yeah, we talked about with a randomized control trial that the benefit of I think, well, Aisha already said them, so I won't say those, but the negatives we feel like were related to representativeness of the sample. Oftentimes it's a lot tougher to recruit, in particular underrepresented minority groups, into randomized control trials. And so that, potentially having a less representative group. And then, we also talked about with you end up with a control group in this case where people don't, those in the comparison condition don't get a chance to benefit, which is, also a negative if we're thinking about community engaged work.
Yeah. It would also be how willing they are basically to use the intervention, because there are many patients who don't really see the benefit of an assistive device, because something extra they have to add to in their daily life. And getting these patients to walk as it is because of their pain in the legs is an issue, and we have to be educated and taught that this is the way that their blockages in the legs will improve by exercise. So having them to be compliant to the intervention is also an issue.
All right, thank you.
Oh, welcome.
And then Did the other group want to go, or would you like us to go?
We can go. We talked about designing a study to address hypertensive disorders of pregnancy, and we talked about using a produce prescription intervention to see if increasing produce consumption could affect the risk of developing a hypertensive disorder of pregnancy. And we talked about potentially doing, in this study, you could potentially partner with local food pantry organizations to give out the produce prescriptions and help identify people who might benefit from a trial or a intervention like this. And so we talked about potentially doing a randomized design with clustering based on the clusters around the partner food pantry organizations. And that's kind of where we ran out of time. So.
Oh, thank you. And then I know you didn't get a chance to talk about the strengths or weaknesses, but thinking through, what you decided to, your design, what you decided to do, what would your group think would be some of those strengths? And then of course weaknesses, if those come up easier than strengths.
Yeah, so I think with the clustering, if you have multiple partner locations, some clustering could help kind of control for variability between the different partners, which would be one strength of using the clustering. And then a weakness of using the clustering is it's just a more complex statistical analysis. So it takes more, I guess, manpower to figure out who you need to recruit more, or like which locations you need more patients from, and all of the little logistical things that go with clustering.
Yeah, I would agree. Anybody else from the group want to add in or chime into what Rebecca provided? I don't recall who was in that group, so.
No, she did a very nice job. We had a great time having the conversation, but we realized that an intervention like this would take, a little bit of time. So that might be a strength and a weakness.
Yeah, thank you. All right, to round this out will be our group. I'm going to let LaDawn explain our design. Well, it was really kind of her design, but we chimed in and asked questions, and then we can talk a little bit about the reasons and strengths and weaknesses. Oh, we lost her. Oh, no, we didn't. There she is. Okay, we lost somebody.
So in this design, we are providing intervention to older adults, rural communities, basically rural and underserved communities of Nebraska, who may or may not have a chronic neurological disorder. And if they do not have it, they basically have some risk factors that makes them prone to cognitive decline. The overall intervention is called intergenerational bonding because we pair each older adult with a UNK student. I come from UNK. And over telepractice, they provide intervention for 3 months. It's going to be a clinical trial with 2 control groups. A group that receives only a tablet and bare minimum education, how to use the tablet, and another group that does not receive anything. But then they switch over time. So it's a wait list kind of a design, and pre-post before and after each intervention. So we will have within group comparisons, between group comparisons, and pre-post for each individual. The strength is that we basically get a lot of good data. The weakness is that it's a very complex design. we rely on area agencies to identify participants. They may not want to stay in the study for almost a year. We do it. The whole intervention is based on telepractice, and we have made a survey all through Nebraska. Almost 50% of the communities in Nebraska do not have access to internet, which means that excludes almost 50% of the population. And also the population of Nebraska is 89% white Caucasian, which basically in terms of diversity, our study is flawed. Sorry.
Thank you. I think we also, just to add to what you said, we talked about it, but more a questioning of, why Shannon asked why maybe we couldn't do it by the agencies, because there's 8 aging agencies that would be involved, and maybe thinking about like clustering based on that. But when we talked about how Nebraska is just kind of so diverse geographically, being urban and rural, some of those agencies are more around more densely populated areas versus those that aren't. So it wasn't really an option to try to do cluster or randomized by agency versus by individual. So we did kind of talk a little bit about that as well. And I think you hit all the points that I wrote down, so nice. Okay, well, I hope that the breakout session and the small activity was helpful, and at least for some of you that these are actually real ideas, thinking through some of the design and methods and what can and can't be done, or really, like we talked about, the strengths and weaknesses of each of these. And even if it wasn't an actual real idea, the hope is that you're able to think through what this would apply to some of the work that you're already doing or planning to do in the future, especially when doing community engaged research work with community partners, and understanding, some of those things that sometimes us as researchers don't think about with regards to the design and then sampling and all of those elements that Dr. Wickman talked about in his presentation. So that's the hope of this activity, and hopefully that did serve you well in having those conversations amongst each other, and then coming back to the larger group and talking through, or at least sharing with everybody what you talked about. Are there any final thoughts or comments for this activity or questions? I like to give that long, awkward pause for the community. My community engagement hat of me, as Paul likes to say as well.